Hello, my dear friends. Today we're going to talk about some entities and pathologies about the musculoskeletal system. We are going to begin talking about functions, physiology, anatomy of the musculoskeletal system. Hi, my name is Dr. Manuel Sosa. I'm here in the Dominican Republic, and today we're going to talk about classes in the clinical knowledge about the musculoskeletal system and some entities of the skin and connective tissues. We are going to provide information you will need to understand certain anatomical dysfunctions, rheumatic diseases, and rheumatologic conditions. Now we're going to talk about shoulder muscle and muscles of the rotator cuff. And the fur of that muscle, and so important to know, is supraspinatus. Suprascapular is innervated by suprascapular nerve, abduced exo, separate and initially, before the action of the deltoid. Most common rotator cuff injury is the supraspinator. It is produced by trauma or degeneration and impingement of the tendinopathy or tear. Another important muscle is infraspinatus. This is also a rotator cuff muscle. Infraspinatus is the innervated by suprascapular nerve. It externally rotates the arm, and pitching it produces a pitching injury. Another important muscle, there are four muscles in the rotator cuff, is teres minor. That muscle is innervated by axillary nerve, and this abducts and externally rotates the arms. The last but not less important muscle is subscapularis. It is an upper and lower subscapular nerve that innervates that muscle, and it internally rotates and abducts the arm, innervated primarily by C5 and C6. Of that muscle, the most important, like I told, is supraspinatus muscle and its flexion, because it don't let the arm to begin in the movement of the abduct and initially abduct or separate the arm. There is the first question we're going to talk about, and the question says, which of the following muscles is named according to its origin and insertion? The first is transversus abdominalis, semimembranous, sternocleidomastoid, or deltoid. The correct answer is C. Sternocleidomastoid muscle is its name, but is according to its origin and insertion. Here we got the fourth slide. Here we are going to talk about arm abduction. There are various degrees of arm abduction and separation, and we're going to begin 0 to 15, 50 to 100, and more than 90 grades in the arm abductions. The 0 to 15, the muscle that intervenes is supraspinatus. That is, it is so one of the most important muscles and a very common asked question. Also, the deltoid muscle with 50 to 100, and the trapezius more than 90, and serratus anterior more than 100 degrees. But of that four muscle, the more important is supraspinatus. So we are going now to continue with wrist region. Here, as we saw on the wrist region, there are so much bones. There are four bones or metacarpal bones. Those bones are scaphoid, one of the most important. Also, it is palpable on the anatomy snout box. Scaphoid muscle is that muscle that is palpable just here on the region of the snout box. is the most commonly fractured carpal bone, typically due to a fall or an outstretched hand. Complications of proximal scaphoid fracture include avascular necrosis and union due to retrograde blood supply from a branch of the radial artery. Fracture not always seen on initial X-ray. Dislocation of lunate may cause acute carpal tunnel syndrome. It's very important to know about scaphoid muscle. It can fracture when we fall with the outstretched hand, and it produces the avascular necrosis and non-union of that bone. Now we are going to see another slides. Here are the number 6, and now we are going to talk about hand muscle. And tenor, we got a median, the opponent policies, adductor policies, and adductus brevis, flexus pollicis brevis, superficial head, deep head, and also we got the hypotenar region. Here is important on hypotenar region. We are going to see various muscles, like the example in the hypotenar region. We see the ulnar region, like opponens digiti minimi, adductor digiti minimi, flexor digiti minimi, and brevis. Here in that region we saw the opponents, the abductor or separate, the muscle that separate, and flexor, muscle that flex on the hypotenar region, like we see here there on the draw of the hands. It is on the proximal side of the hand and on the palmar region. On the other muscle is dorsal interossei. That muscle are in the ulnar region and that separate or abduct the fingers, and palmar interossei that abduct the fingers, so this get the muscle more proximal. Palmar interossei are more proximal, and dorsal interossei separate or abduct the fingers. Another important muscle, like we are talking, is lumbricals. There are four lumbricals: first, second in the median region, and third and fourth on the ulnar. That muscle, the function is to flex at the metacarpophalangeal joint and extend proximal interphalangeal joint and distal interphalangeal joint, like we see here on the on my hand. And the lumbrical muscle flex the metacarpophalangeal joint and extend distal and proximal interphalangeal joint. That is the correct function of the lumbrical muscle. Now we are going to talk about another slides. Here, for example, we see some lections of the nerve, upper extremity nerve. We are going to see now etiologies of the lesion, causes, and what are the signs and symptoms or presentation of that lesion. For an example, we have axillary nerve. It is a very question nerve and very important. It goes from C6 to C5, and the etiology of injury is fracture of the surgical neck of humerus anterior or in anterior dislocations, like for an accident involving the shoulders. And the presentation is the flattened deltoid, loss of an abduction separation of the shoulder in the more than 15% of the angle, and loss of sensation over the muscle and lateral arms. Another and so important muscle nerve lesion is musculocutaneous lesions. It goes from 6 to 5 to 6-7, and it caused by the upper trunk compressions. And this in the presentation we are going to see like descent the B6 from C6 to C5 to C6, or 3 sets in the C7 region of the dermatome in this of the mutant. This reflects weakness of the forearms, flexion and supination, loss of sensation over lateral forearms. That is the lesion of musculocutaneous nerve, in which we are going to lose the sensation on the lateral forearms regions. Another important lesion of nerve lesions is radial nerve lesions. Radial nerve goes from C5 to T1, and this can cause the injury by a compression of axilla, for example, due to crunches or sleeping with arms over chairs. It is called Saturday night palsy. Mid-shaft fracture of humerus can be the etiology of the Saturday night palsy or the lesion of the radial nerve. And the form of presentation of that lesion is the wrist drop. So the wrist is going to be on descending position, like that's why the wrist is gonna be drop. Drop wrist is the present form of presentation of the radial nerve lesions, and this also is the loss of elbow, wrist, and finger extension, loss of sensation over posterior arm and forearm and dorsal hands. It is a very frequent asking question on exams. In the radial nerve, we have right drop, and also loss of sensation over the posterior arm, forearm, and dorsal hands. So you got to get in mind that question when you are fully your exam completing. Now we got another slide, and we are going to continue with the introductions. Now we are going to talk about two very important next. It's the median nerve and ulnar nerves. The first of that lection nerves is median. Median nerve goes from C5 to T1. It is recurrent branch. There is no loss. This is the lesion of the recurrent branch of the median nerve. There is no loss of the sensations. The etiology of the injury of the median nerve are supracondylar fracture of the humerus, proximal lesion of the nerve, carpal tunnel syndrome, and wrist laceration, distal lesion of the nerve. And the presentation, the signs and symptoms of the median nerve lesion is apple hand or Pope's blessing. This is a loss of wrist flexion, flexion of the lateral finger, some opposition, lubricant of index and middle finger, loss of sensation over the thenar eminence, and dorsal and palmar aspect of the lateral 3.5 finger. There is a loss of sensation of the lateral 3.5 finger. So we lost the sensation on the lateral 3 hands, and the halves of the fourth finger on the half lateral side is going to lose the sensation over that fingers 1, 2, 3, and lateral half of the fourth fingers. And so also a very frequent asking question. We are going to continue to resume on the ulnar nerve. Ulnar nerve is located from CX to T1, and the etiology of ulnar nerve lesions can be a fracture of the medial epicondyle of humerus, funny bone or the funny bone, proximal lesion, fracture of the hoop of the hamate, distal lesion from 4 on our strange hands, like for example on the lesion of the scaphoid. We're talking about a 4 on the strange hand. Also here on the ulnar nerve, we got the same lesion. So the clinical presentation of the ulnar nerve lesion is ulnar claw. On digit extension, when we extend the digit, radial deviation of the wrist upon flexion. Proximal lesion, loss of sensation over medial 1.5 finger, including hypothenar eminence. So on the median lesion, on the ulnar lesion, we have the loss of sensation of the fifth finger, the finger, little finger, and a half median of the fourth finger. So we lost the sensation over that area here on that fingers. So is a very also a very common asking question. The lesion of the ulnar nerve is something you got to learn if you want to pass on the exam. If you are practicing painting on the clinic, you also gonna be that lesion of the ulnar nerve. So it's so important you learn where are located dermatomes, because if you know what are the dermatome affected, you also know the myotome, what are the nerves, and what is the skin innervated with the nerve. You're going to know what is the loss of sensation. You also can have a lesion called hyperalgia. So hyperalgia means you got pain on the skin area innervated with the nerve. Like for example, if you had loss of sensation in the palmar region of the first, second, third, and lateral half of fourth nerve, you got a median nerve lesion. But one of the most important lesions is musculocutaneous lesion on the lateral side of the and of the forearm, and also a very important lesion is the ulnar lesion in the fifth finger and the medial side of fourth finger. So here we are seeing ulnar lesion is on that area, red area. We got the lesion of the ulnar nerve. It is so important question on your exam. So now we are going to follow with that lesions, and here we are going to finish that part. It's only introducing the topics. Later, we are going to begin talking about a very important question. We are going to talk about brachial plexus lesions, a very important lesion, erosion palsy, and the right teeth. So it's all, and I wait to see you in another presentation. Thank you so much.